Hello, welcome to Supporting People with Co-Occurring Diabetes and Depression. My name is Tammy Chambers and I'm a clinical quality consultant with Health Partners. This webinar is brought to you by these 8 managed care plans, and they are called the Collaborative, which impacts the SMBC and MSHO populations. Over the next 3 years, this performance improvement project will be focusing on addressing the complexities of co-occurring diabetes and depression. From our research, there appears to be a bidirectional relationship between diabetes and depression. A person with diabetes is at increased risk of depression, and a person with depression is at an increased risk of getting type 2 diabetes. All plans across the U.S. serving Medicaid members are required to do a PIP. DHS collaborated with us to establish this as a priority project. All plans have multiple initiatives in place to address this crisis, but the PIP allows us to formalize this work and collaborate on interventions and bring them statewide. This project must be designed to improve the quality of care and health outcomes for Medicaid members, address a serious health condition, improve member satisfaction, with a goal to achieve significant improvement sustained over time. And this PIP addresses all of these areas. We will have time and opportunity for questions at the end. You can also add to the Q&A. Thank you again for joining us. Today's presenter is Mary Holland. She's Director of Behavioral Health Case Management at Health Partners. She's a licensed professional clinical counselor with 15 years of experience in the mental health field. She began her career by providing individual and group therapy to children and adolescents before moving into case management. Through her case management experience, she has supported adults with severe mental illness through community-based case management and Mental Health Resources, Inc., as well as telephonically through Health Partners. In each role, she has worked closely with individuals and families to educate them on mental health and assist in navigating care and resources with the goal of helping each person improve their health, independence, and overall well-being. Throughout the past 8 years, she has been using her case management expertise to lead the Health Partners Behavioral Health Case Management team and aid into the facilitation and improvement of behavioral health initiatives throughout Health Partners Health Plan. Welcome, Mary.
Hi, everyone. Thank you. Thanks for everyone for joining today. This is a great topic, and I'm excited to talk about it. As Tammy shared, I have a background in education and counseling, and really thought I would be doing counseling and therapy at this point in my career. But like my bio explained, I've really landed in the case management space for most of my career instead, and I have been able to use all that counseling experience just the same. I mean, we're constantly in contact with people who are experiencing mental health needs, which is just a growing area of health throughout our population. And so every day we're working to improve the mental health of individuals and learning more about how it coincides with physical health. And so that's where I'll be focusing my talk with all of you today. So there's going to be 3 main areas I'm going to be focusing on throughout the next hour: the importance of mental health and how mental health interacts with our physical health to create a mind-body connection, and then how we can support individuals through a holistic or a mind-body lens when we're managing co-occurring or helping them manage their co-occurring conditions such as diabetes and depression. Before I get into all of that, though, I want to share about this image. I really love this image as we think about comorbid conditions like diabetes and depression, because it can become such a balancing act for individuals who are already experiencing maybe one condition, to then add things on top of that, add another condition on top of that, and manage all of that in a way that keeps things from towering over or from getting worse. In this image, if any one of those rocks begins to wobble or isn't set right, then the others start to wobble and potentially fall over as well. And so even when we are, working to build up our support or manage ourselves in a way that we really feel confident in, there's still things happening around us that can always, push the tower over, so to speak. in the instance of this rock formation, it could be the weather around it, it could be waves, animals, people, and we see that same impact in our health as our environments ebb and flow, and then sometimes support us in the management of our health, and at other times create challenges. Next slide. So I really want to highlight just the importance of mental health before we get into that mind-body connection. So why should we care about our mental health? Well, there's several reasons. First and foremost, mental health struggles are very prevalent. You can see as many as 1 in 5 adults and up to 1 in 6 children experience mental health disorders in any given year. And those mental health challenges can begin very early in life, some in childhood and adolescence, others in early adulthood. Sometimes they do begin a little bit later in life, but nonetheless, they do have the possibility of lasting throughout the lifetime, particularly if they are untreated or undertreated. Our own mental health impacts not only us, but those around us. Caregivers feel this quite a bit. You can see in the statistic there that they can spend many, many hours per week providing care to someone with a mental health condition that often goes unpaid. It may go kind of unnoticed, but it is still part of the whole picture. And lastly, mental health does impact our physical health, which we all know. But as Tammy pointed out, people with depression do have higher risks of developing physical health conditions, such as cardiovascular or metabolic diseases or diabetes, which we'll get into more in just a few slides. Next slide. So the mind-body connection is really a link between how we think, how we feel, our attitudes, and our overall physical health and functioning. It really signifies how emotions and stress in our life can influence our overall health or our longevity, and how in turn our physical health and the actions that we take to manage our physical health can shape our mental states. This mind-body connection is a really important component to holistic care and support, which really seeks to treat the whole person, not just the symptoms of any one or any of the conditions that they're experiencing. So it's not enough to think, but let's really address diabetes, and then we'll move on to addressing the depression. And so I want to reiterate the connection that Tammy made. The risk of depression can increase the risk of diabetes, particularly type 2, and that risk of diabetes can increase the risk of depression. And when both are present, the diabetes and depression can in turn potentially make one another worse. Next slide. So let's dig into this connection a little bit further and take a closer look at how that mind-body connection creates and maintains that connection between diabetes and depression. This diagram, this circle on the screen, is based in cognitive behavioral therapy. So if you're familiar with that type of model, you can kind of think of it as a triangle where thoughts are on one point, feelings are on another point, and behaviors are on the third point. And in turn, the thoughts will influence the emotions and the emotions will influence the behaviors and the thoughts, and the behaviors will influence the thoughts and the emotions. So they're all working in combination. And similar to that rock image, as one is impacted, the others are likely going to be impacted as well. So as someone begins experiencing a change in their physical health, they may experience thoughts such as, what's going on with me, or I'm not getting better. Why am I not getting better? And that can really drive feelings of confusion or frustration or fear that in turn can influence actions that they take or may not take to manage their overall health and function on a day-to-day basis. They may also seek out more medical support or may avoid medical support as a result of this. They may isolate from others or withdraw from activities that would otherwise be a part of their daily life. And instead choose activities that would feel easier, but in turn not be as supportive of their overall health. In the case of depression and diabetes, it can be that same cycle with really no clear or consistent start or clear or consistent endpoint. So things like monitoring blood sugar, dosing insulin, planning meals, staying or at least attempting to stay active become not only a lot to do, but a lot to think about. In turn, those actions can really lead to physical and mental exhaustion, frustration, irritability that can impact, again, the efforts that someone is going to make or not make toward their the management of their diabetes overall. You may have heard of this cycle as the diabetes distress or burnout, and where the management of diabetes starts to really falter, and those emotional and cognitive struggles increase, although they may not really be yet full-fledged depression, but can absolutely mimic depressive symptoms. Next slide. And that really brings us to the question of what does depression look like, or how would someone know that what they're experiencing is, possibly just day-to-day stress, or diabetes distress, or even depression. These are really important yet still challenging questions to answer for a couple of reasons. First of all, the symptoms of one condition, as you can see on the screen, mimic the symptoms of another, particularly, changes in appetite or weight, changes in sleep or energy level, fatigue. Some physical symptoms may be present in both. So even when we understand and feel confident in what each condition looks like separately, it can still make it really difficult for us, or even the person who's experiencing these things, really understand which is which, and how to address it. And ultimately, as this, we're talking about, the two conditions are absolutely able to be present at the same time. So, if and when I give this talk again, I will probably adjust this title to be not depression or diabetes, but depression maybe and diabetes, because they're just so intertwined. And so when we think about depression, we all experience changes in energy, changes in mood, changes in sleep or appetite, which are just influenced by our day-to-day experiences and the situations that we engage in. We all have and we will feel something or other on both sides of these symptoms lists, but eventually they reside. They reside as the situation evolves, as we move through things, but it's really when these kinds of symptoms or experiences start occurring every day, last longer than we would expect them to, or impact our overall daily activities, that we want to really be thoughtful that it could be something more than just the ebb and flow of life, and could be truly indicative of depression. Next slide. So as these statistics highlight, that risk for depression, or between depression and diabetes, is unfortunately not uncommon. People with diabetes are 2 to 3 times more likely to have depression than people without diabetes. And it's even estimated that up to 25% of individuals with diabetes, while they may not have clinical depression, may still experience those depressive symptoms. Unfortunately, a lot less of those individuals are getting diagnosed and treated. And why is that? Why are so few people, in comparison to the overall population who experience these things, getting the care and the support that they need. One reason might be that overlap of symptoms that we just talked about that make it difficult for people to identify depression within the rest of their symptoms, particularly if they're not knowledgeable about what depression can ultimately look like. It's really easy to think that someone who is depressed, is just sad or would be staying in bed or just avoiding the activities that, like I said earlier, they would typically participate in. But we know that the symptoms of depression, like sadness or a decreased interest in activities, are only a few of the ways that depression can show up. It's important to keep in mind that other things that we don't inherently think of, like irritability or physical aches and pains, could be part of that picture as well. It's also possible that people who are experiencing those depressive symptoms just may not know where or how to get help. Or if they have that idea of where and how to get help, their confidence in navigating the system to do that is lacking, and that's okay because it's a complicated system. There's a lot of challenges within the healthcare system, but hopefully those are things that clinical supports and others around them would be able to help them navigate. Because as they start down that journey, it's not uncommon that they may run into things like struggles with finding available care, establishing connections with a provider, or even just having the basic resources, insurance or the finances to afford that type of care. So we just want to keep in mind all of those things that people are encountering along the way, especially within the mental health field right now. Access has been a big focus in the last several years, particularly since COVID, where mental health care is just more highly utilized, and that in turn creates a lot less open care for people who need it. Additionally, mental health is unfortunately very highly stigmatized still, where it can be believed that if you experience a mental health challenge, that's not okay. In turn, that can trigger those feelings of embarrassment or shame or guilt that can keep people from asking or seeking out the help that would ultimately be in their best interest. But as that last circle shows, even when people are managing their diabetes well and have periods of stability, it doesn't keep them from still feeling that stress that comes with the condition. Up to 50% of people who do have that period of stability still experience those feelings of burnout, or could experience those feelings of burnout. And that again makes them more susceptible to depression overall. So because of this, it's really important that we're addressing health holistically, not only for those individuals who are newly experiencing one or both of these conditions, but even for those too who have been living with these conditions for quite some time. Next slide. So with diabetes, feeling physically well is half the battle. Feeling mentally well is the other half. So as I mentioned previously, treatment approaches that are whole person focused, that address both, diabetes and depression or mental health in general, simultaneously are going to be really important. Caregivers or providers who understand how to support a person in these ways, as well as how to help the individual gain that confidence and those skills to address their health as independently as possible, will also be really important. So as we dive into this second part of this discussion, we'll cover the approaches that are listed here, how to create that connection and rapport with others, how to attend to feelings and thoughts that people may be experiencing and playing a role in their overall health management, not just the behaviors that we would expect them to be participating in or engaging in, but then educating them on how to take that more active self-management approach to their own health and enlisting the care and support from others when that's needed. So these might not be new approaches for many of you on the call today, but at the very least, I'm hoping that they can help refresh or reinforce or even remotivate you in your work to incorporate them or reprioritize them, so we can help individuals, feel that we are helping address their overall health, and in turn that they can take that same approach. Next slide. Establishing connections with others is such a key component to working effectively with individuals, not only those with diabetes and depression, but really anyone that we're working with throughout, the healthcare field. A lot of the skills that are listed here are based in motivational interviewing. Motivational interviewing is a fabulous approach. It has a lot more to it than what I'm going to talk about today. So if you're not familiar with motivational interviewing or are looking to gain further skills in that, keep eyes and ears open for opportunities to do that. It's just such a useful and effective strategy at helping people find their inherent motivation to change positively and overcome any ambivalence that they might be experiencing and kind of keeping them stuck in old habits. But I do want to highlight some components of motivational interviewing that can be used to create that connection. First and foremost, showing that genuine interest in the person that we are interacting with. We live in a very fast-paced world right now. Multitasking, unfortunately, seems to be becoming more of a norm. So, giving our uninterrupted attention to others that we're interacting with, that we're working with, showing them that we genuinely are interested and care about them as a person, by simply just asking open-ended questions and allowing them to share what and how they're doing. How are you doing? How are you feeling? What is important to you? Sometimes these don't even come in the form of a question as much as they do in the form of a statement. Tell me more about that. Share with me what that was like for you. Say more. These don't have to be long, drawn out questions, but just prompts to open that door and let someone know that you are curious. You want to know about them and what they're willing and comfortable to share with you. And as they do start sharing, acknowledging what they are sharing with you, providing them that time and space, and acknowledging, and then reflecting back to them what you are hearing and what you're sensing non-verbally as well. Just to help them confirm that we're there with them and we are working to understand them again as a whole person. So, I hear what you're saying. Your doctor recommended a follow-up appointment and you have concerns and questions to discuss with them, but all the upcoming appointment times conflict with your work schedule. And now you're thinking, what's the use? You're exhausted from trying and mad that the clinic isn't more accommodating. And so that can be just, an example of how to acknowledge and reflect back what a patient or a client or a member may have shared. Additionally, affirming the positives. As we work with individuals who, will share a lot of what's not going well for them, or even as our own work drives focusing on presenting problems or the needs of a patient or a member or a client, there are still good things happening. And we want to keep those in the forefront as well. So looking for and affirming with that person, what strengths they're displaying, what you're hearing, what you're picking up on. You've shared about your children a few times. Being a mom is really important to you. So not even, the strengths that they're displaying in terms of their health, but in their overall life. And then as we, take all of that information that we've learned throughout those conversations and those dynamics and start moving into a planning phase. We really want to work collaboratively to create those shared goals and actions, not only considering what is important for the person. We all know it's important for people to take their medications, for them to go to an appointment, so they can, manage their health overall. But even more so, what is important to them? It's important that you're able to spend time with your grandchildren. It's important that you can get out and go for a walk with your dog every day. Again, really uncovering that inherent motivation, their purpose that will hopefully be their reason to do all the things that are important for them. So even though these skills are displayed here on the screen in this linear model, keep in mind that they're very fluid. These are not things that are kind of a one and done step or approach. These are very dynamic. They are going to happen repeatedly. They're going to happen recurringly. And so it's okay to move back and forth across this as care unfolds with a patient. And these things don't always have to be rushed. We don't need to move through them too quickly. Rather, we can allow people the time to share about themselves. We can allow ourselves the time to reflect that, and even kind of pause and give that space where that's needed. Because people will start to, process a lot in these interactions as well. Next slide. And so as much as we all like to get into action steps, action planning, what are we going to do? What education can we give the patient? What referrals can we make? What appointments should they go to? I'm sure we've all experienced the challenge with a patient or many patients where we get those action steps identified, we lay them out, we put them in the care plan, but they don't happen. And why aren't they happening? One potential thing could be, have we really addressed how the member is feeling and what they're thinking, and how those components of that model, that mind-body connection, might be playing into the overall plan. And so when we are, focusing only on those behavior-oriented steps without understanding those feelings or those thoughts, we risk misunderstanding the person's needs or their preferences, or really where they're coming from, or what might be keeping them from following through the way that we would hope them to. But we can really help to set the stage and open this door to bring thoughts and feelings more into the forefront, and highlighting them as an important component of our overall work. We know that it's really hard to get into those action and planning steps when emotions are high. So bringing those emotions down where we can, have more of that rational and planning-oriented conversation is really important. I have young children, and it's not uncommon that they have big emotions, and that's okay. And I think it's really important, and I've found it really helpful just in my experience as a parent, that I'm hoping, I try to be mindful of in my professional work, that it is okay to feel your feeling. Be sad, be angry, be confused, but let's do it in a way, let's manage that emotion in a way that's going to keep ourselves safe, that's going to keep others safe, but it's okay to feel how you're feeling. And once that does start to subside, we can move into more of that identifying and naming part of it. What was that? What was going on for us in that moment? And I have seen this in my daughters, where once that feeling comes down, we can talk and say, that was really frustrating. You felt really sad. And having that, state of calm or clarity, even as a young child, they can sometimes reflect that, I did feel sad. And then taking it one step further, what were we thinking? What was the patient thinking that was underlying or driving those emotions. And so that's a really important step, because sometimes these thoughts that drive our emotions are spot on, they're completely accurate, and sometimes they're not so much. So really kind of naming that feeling in combination with the thought. You were angry because you didn't think others were listening to you. And then taking that one step further to reflect, or help them even reflect that, yeah, I was angry because I didn't think anyone was listening to me. It is possible they just may not have heard me. But all of that is hard to do when emotions are high and, we're not in that space, even ourselves as providers, to be able to think more calmly and rationally about what's really driving that immediate reaction. Next slide. So it is possible throughout these interactions, and you may be wondering as you get into these conversations or as you're having these conversations, if mental health isn't your area of expertise, how do you bring up a more focused conversation about mental health, or how do you respond as an individual shares with you that they are experiencing mental health challenges? Unfortunately, there's no right or wrong way, or one or right way to respond or to open up these conversations, but rather it's really relying on those connection points that we just talked about a few minutes ago. Building that rapport, showing that genuine interest, asking those open-ended questions, acknowledging and reflecting what you're hearing from thoughts and feelings, and affirming the strengths, while also really being mindful of things that could be less helpful to the conversation. Unsolicited advice, I really think you should just go do this, or using a language that could be taken insensitively or feel dismissive. It could be worse. Everyone experiences that sometimes. One fairly recent example that I can share around this, it wasn't too long ago that someone pretty close to me had reached out. I could just tell that they weren't doing well. And I wanted to really make sure that they were okay, not just given my role in mental health, but because, they are someone very close to me in my life. And so having a fairly upfront conversation, but yet still kind of an open dialogue about how are you doing? You don't seem like yourself. Tell me what's going on. And as we started to talk further, it really came out, and I was able to reflect back that it doesn't sound like, or it sounds like you don't feel appreciated. And it sounds like you believe others are, getting the same or more recognition for doing less. And it really hit home. I'm not saying that, this is an easy thing to get to with people, because it's not always obvious, what they're telling us. But once we kind of get to that point with people where, they are feeling heard, they will be able to let us know, either through their emotions, or just by saying like, yes, that's what I'm feeling, or no, that's not really quite it. I think it's more like this. So again, it's, leaning on all of those interpersonal dynamics that can allow people to feel heard and seen and share what their experiences are. Next slide. So finally, as we move into more of those planning and action steps, it is important to consider both the actions that clients or patients can take to manage their health themselves, and also what care or support that they may need from others. And so we'll discuss both strategies for self-management, as well as strategies for enlisting care or support from providers or other others throughout their network. But first and foremost, what is self-management? Self-management is really the ability to, for someone to regulate their behaviors and their thoughts and emotions in a productive way that they can then hold themselves accountable to doing what needs to be done for the benefit of their health. So, the actions listed on the left are great practices. We all know that these are, recommended practices, things we all could and should be doing in our everyday lives. But they can be pretty complex actions when we break them down. And so I think it can be helpful to take a step back from those and really help identify within them what is possible for a person, what is a step in that more positive direction, so to speak, that an individual can clearly understand what to do or how to do it, and they have some reasonable likelihood of achieving. So thinking about eating well, having good nutrition, getting well-rounded meals in each day. Is there one component of that we could draw out and help somebody focus on? Adding in fruit to a meal, or something that really breaks that step down into a reasonable component that they are able and willing to do. And the rest of those listed on the right there, just doing that one or even just a few simple things at a time, and giving appreciation to that. Sometimes just resting is as helpful as being active for some people. It's really going to be important to consider, who the person is, what they need, what they want to do as you help them identify what is going to be useful for them. Same as, the social interactions. In some instances, it might be helpful for them to connect with others, and in others, they may just need some alone time. But also then changing their environment or focusing on their surroundings and senses in a way to really help themselves in that moment that can in turn get them into a place where they can take action on more complex steps. Next slide. So as I mentioned, managing health obviously doesn't need to be done alone. It's important to consider, again, what people can do for themselves, but also what do they need from others? What care do they need from their clinic or other professionals, and how can we help them enlist that care in a way that works for them? So some ways to do that, really just helping people identify their needs and their preferences and what options there are for them to engage in, thinking beyond just medical care, but more broadly to behavioral health care, which could be therapy, it could be psychiatry. What other community options might there be? Support groups, family, friends, religious organizations. Really taking into account what options there are across the spectrum. Empowering the patient or the member to speak up. This can be really difficult when they have things that are just not going well for them. What questions do they ask? Who do they bring those questions to? How do they say that they're not feeling well or that things aren't working? So really supporting them in taking that assertive approach to share with others what is going on for them and when. I know for me, even I've gone as far as writing my questions down as I go into an appointment, because you get in there and it's hard to recall everything that you've been experiencing or thinking about in your day-to-day life leading up to an appointment. So having things really clearly in front of you as you go into an appointment can just help get the information that is needed for you to take back, or to let your provider know how you're doing. And then once you have, or once the patient has that care established, connecting with them to really understand what is their recommendation and how does that fit with the member's overall preferences. Is there other specialties or treatment recommendations that they have? How have those worked in the past if they have been attempted or tried in the past? What other considerations need to be kept in the forefront? And this is where, as we think about the diabetes and depression connection, keeping those treatment options in the forefront and the providers connected can be so important, especially as we think about the medications people might be on, or the other recommendations that they may have been given. How are those impacting one another? Is one making another worse? So keeping those conversations open can be really useful. So if something, again, isn't going well, it can get talked about. And finally, exploring care and support options available that align with their preferences, like I had mentioned, and keeping options open to make adjustments along the way. Next slide. So I'm going to talk a little bit more about mental health care in particular. There's a lot of options for mental health care, ranging from the community options listed there on the left to more intensive or acute options listed all the way to the right. In the middle, we see some of our outpatient care options that could be considered. All of these can or should be talked about, with providers who are overseeing a patient's care. So it's really clear, what care is being provided and how it's working. But these are, I think, some of the general ones that we could see or could consider as we, again, help individuals start to navigate how to address their mental health care in the context of the healthcare system. Next slide. And of those options, I want to dig a little bit deeper into therapy. You may be asking, isn't therapy for someone who has had a really significant mental health issue or is experiencing unresolved trauma? Of course, it can be for those individuals. It can also be for others who are going through, new experiences or other challenges. It doesn't, we don't have to wait until we get to the worst feelings or emotions or situations to consider therapy in the context of our overall health care. And so it's very reasonable to work with individuals and help them explore therapy as an option for seeking more clarity in their thoughts and their feelings and how those work together to process more traumatic experiences or challenges, or even just for personal growth and to learn new coping. So there's a lot of really beneficial reasons that people can go to therapy and how it can overall help the management of not just their mental health, but in turn their physical health as well. If we think back to the beginning of the hours, we were talking about the diabetes depression connection. If we're managing our emotions well, if we're managing our thoughts, that in turn will help individuals keep themselves engaged in the actions that they need to be doing for diabetes and their physical health. They are at a better chance for success. Next slide. So I'm going to start to wrap us up with just some general mental health resources that are hopefully known to many of you, but if not, I wanted to share a little bit about them. Make It Okay is a public campaign to fight the stigma associated with mental health by making it okay to talk about, making it okay to experience. And so the website is listed there, and I encourage you to jump out and take a look at that. Direct patients or clients to it. There's just so much good testimonial and advocacy information out there to, again, help fight the stigma that is so commonly associated with not only mental health, but substance use as well. NAMI, the National Alliance on Mental Illness, wonderful resource for education and advocacy. The Minnesota chapter, the website to the Minnesota chapter is listed there. And then lastly, just keeping in mind the updated options for suicide and crisis prevention. The new 988 number and chat are available for individuals who might have a more immediate mental health need. So those are, really nice resources to just keep in the forefront for both ourselves and anyone that we may be working with. All right, next slide. So that kind of brings us to questions. I'm happy to take any questions that you may have thought of throughout the presentation. I believe they can be entered into the chat and that they'll be shared out. So.
Mary, we have a question about the 988. Does that replace the 800-784-2433 for crisis intervention?
In all honesty, I can't think of what the 2433 number exactly goes to. Not having all of those numbers memorized in the past, but 988 is a very broadly used just simple crisis resource that I believe it was within the last year or two. I forget the exact date, but some of you may know better than I do. But it is the kind of mental health avenue or equivalent for 911. So if there are other crisis options that still exist, it'd be worth, looking those numbers up or checking them out through websites just to confirm if they're still in use, or if some of those have transitioned over to just the 988 in general.
Great, thanks. Do you know why rates of depression are higher in individuals with diabetes?
There's a lot of research out there, brain chemistry and lifestyle factors, and there's a lot of different explanations for why. I think one of the simplest ones is we're looking at the connection between depression and type 2 diabetes. Again, it can really play into the management overall. And I'm not saying that that's the only reason, but I think that's a very common connection that we're seeing in terms of how someone is managing or not managing their diabetes or lifestyle practices that could in turn lead to higher rates of depression.
Yeah. Do you have any advice for discussing mood or mental health concerns with someone who has difficulty sharing or being able to pinpoint their exact emotions, but knowing that they're feeling unwell? I think that is a lot of us.
Yeah, it's a very good question, one without one exact answer. I think giving some time, giving some space. Sometimes it's more about reflecting back to them that, it just seems like this is hard for you. It seems like this is a hard topic to talk about. It's hard for all of us to talk about. It's hard for us to talk about who have been doing this work for years and are trained in this sometimes. And so just kind of giving that grace and that space. Again, sometimes I think we'll be able to pick up on potentially what someone is feeling if they haven't named it themselves. By naming it potentially for them, it could help them say, yeah, that does feel like where I'm at, or, no, that's not quite right. But ultimately knowing that, if they're not feeling well, we are hearing, we're seeing them, and it doesn't have to be something that we have to pinpoint on the dot. And it's also going to be something that's going to be changing. How they're feeling today may not be how they're feeling tomorrow, and may not be how they're feeling next week. So just to allow them that space to know that this is that health is an ebb and flow and an evolution.
Do you know if there is a correlation in data that shows whether or not depression comes first or diabetes comes first or vice versa?
I don't have any statistics to say, of the people who experience both, what comes first, if there even is, if they've pinpointed information to that extent. It can be both. It's not always one, it's not always the other. And so I think that's just a really important thing to keep in mind, that it's going to differ. But just to keep in mind that, they are very intertwined, and one can influence the other. So, if someone that you may be working with only has diabetes, how can we kind of take this knowledge of what we do know and help them even address their mental health, knowing that they may not have depression or even be feeling depressed, but they're at a higher risk. So keeping that as part of the overall focus, because we all have mental health. We all have thoughts, we all have emotions. So how can we all attend to that to keep ourselves well?
Yeah, and there's a couple of comments about the 988 number. One person responded to the question about whether the 800 number was a replacement. He is saying that the 800 number is for local crisis response line, and 988 is the nationwide number. And I didn't know the 988 was nationwide. Do you happen to know if the 988 has interpreters or not for non-English speakers, or if they have Spanish speaking staff?
That is a really good question. I don't know if I've ever asked that. I'm not sure myself. That is great, a great thought, but I don't unfortunately have an answer. So I would encourage you to Google or look
and
at
other
that.
people answering the question in the Q&A. So thank you for all the experts that are on the line.
Yeah, I appreciate the comments. So thank you for adding that in. If you've experienced using that in other languages.
Yeah. And there's some other questions about prevalence of other chronic conditions with depression. If depression is more prevalent with diabetes than other chronic conditions, or if you have any sense of that at all.
I don't have specific, statistics or rates of other mental health conditions in relation to other physical health conditions, but there is that general correlation between, again, physical and mental health. And so it's not uncommon that we see, depression in the face of schizophrenia, as one example. So I think it's always a really good thing to keep in mind. If you're working with a patient or a client that has one or the other, that, but they have depression, they may not be presenting or experiencing physical health. That might be a driver for how they're managing physical health overall, or vice versa. But I unfortunately don't have other statistics to share right offhand.
Yeah. There's some questions about other population-based statistics, and I wonder if that they mean different population race correlations, socioeconomic factors that can impact depression and diabetes. If we know any of that kind of information too. Excuse me.
Yeah, just kind of looking at the question around socioeconomic factors that play into the impact of depression and diabetes. That gets into a little bit of, the recommendations and the actions in terms of housing, connections with other social networks, financial resources, insurance or whatnot to cover food and the choices that people have in terms of food and medication. So there's a lot of social factors that play into both, that again could really help somebody when those socioeconomic factors are addressed, but could also really hinder or exacerbate some of this when they're just not addressed.
Thank you. And we are at time.
Yes.
Yeah.
Can you hear me, Patty?
Yes.
Okay. Hi. Thank you, everyone, for attending today, and Mary for presenting a great presentation. So in order to receive the certificate of presentation, please fill out the evaluation. We really find that beneficial when we hear back from those who've attended. And the evaluation link will be sent out in the PDF version of this webinar and available in the chat. And it will also be posted on the Stratus website link along with the recording. If you have any questions, you can feel free to reach out to me or Patty as well. So thank you again for everyone for attending, and have a great rest of your day.